This is the third and final lecture in the series about antibiotics, bug versus drug, where we talk about the non-beta-lactam antibiotics. So in considering the non-beta-lactams, it's useful to consider them as in two groups: the injection-only non-beta-lactams, which are the glycopeptides and aminoglycosides, and the ones that are available as oral and usually IV formulations as well, which include ciprofloxacin and other quinolones, clindamycin, azithromycin, cotrimoxazole, and doxycycline. So vancomycin is a drug that's got quite strong gram-positive activity, and it particularly has anti-MRSA activity. It wasn't used very much until MRSA became a problem because it's only available as an intravenous formulation. Early preparations were nephro and ototoxic, particularly if given with gentamicin. More modern preparations are more highly purified and seem to have a lot less of this toxicity, and they're considerably less toxic than aminoglycosides. Glycopeptides, particularly including vancomycin, do not have any anti-gram negative. There's no anti-gram negative activity, and there's activity against gram-positive anaerobes such as anaerobic streptococci, but there's no activity against the pathogenic strains of Bacteroides and other gram-negative anaerobes that are important in gut-related infections. The other major group of non-beta-lactam injectables are the aminoglycosides, of which gentamicin is the most commonly used. Aminoglycosides don't have useful gram-positive activity, except they are used in synergy with beta-lactams and vancomycin for enterococcus. This is usually in the setting of endocarditis. Sometimes the aminoglycosides are used for atypical mycobacterial and some other unusual infections such as brucellosis. But by and large, the use is in the aerobic gram-negative organisms. They are the most rapidly bactericidal agents against these organisms, and this is why we favour using them in bacteremic infections, because they will kill the organism most quickly. They are quite toxic to the kidney, and they are also quite toxic to the balance organ and the hearing. And so it's recommended to only give them for a maximum of 48 hours because the toxicity then becomes unacceptable, unless they're being used for the synergy reason to treat endocarditis. If you treat enterococcal endocarditis with beta-lactam or vancomycin without gentamicin, there's a much higher failure rate, which is why the drug is used for the prolonged period in this infection. But for treatment of gram-negative infections, really source control is paramount. So if there's an abscess or a leaking anastomosis or something like that, that needs to be drained, and the patient should be on alternative gram-negative drugs if they require a longer treatment. With respect to the non-beta-lactams that are available as oral agents, as mentioned, ciprofloxacin, clindamycin, azithromycin, cotrimoxazole, and doxycycline are the ones that are available. It's important to note that the bioavailability of each of these drugs is very high, and so you can usually use them to treat the patient via the oral route rather than the intravenous route. They really should only be used intravenously if the patient has to be nil by mouth, or if there's some problem with malabsorption. So if it's an acute surgical patient that needs IV antibiotics, they need to have these IV if it's indicated. But when they can take pills, then they can be converted quite quickly to oral antibiotics. So starting with ciprofloxacin, this is a very good anti-anaerobic agent and was the first oral and is the only oral antibiotic that has anti-pseudomonal cover. And so with infections with this organism, it's quite useful in the oral phase of the treatment. It's got very good coverage against the gram-negatives, including the more resistant ones. Unfortunately, with the widespread use of this drug, there's a lot of resistance emerging, and it's particularly overseas where many, if not most strains of E. coli, for example, are now resistant to this antibiotic. Clindamycin has very good gram-positive activity as well as anti-anaerobic activity. It's got no useful activity against enterococcus nor against anaerobic agents. So if one was treating, say, a penicillin allergic patient who had a mixed infection, you would need to have gram-negative coverage with another agent if this drug was used in treatment. Azithromycin is an unusual antibiotic insofar as its coverage against the conventional organisms is not quite as good as we'd like, but it has particular place in respiratory infection against things like chlamydia and mycoplasma and Legionella pneumophila and Longleachii. There is use in urinary tract infection in some resistant cases, and it has a particular use in enteric fever due to Salmonella typhi. Cotrimoxazole has got fairly uncertain coverage for our gram-positive organisms and E. coli. It has also got patchy anaerobic activity, but it's used for things like Pneumocystis hiruvecii pneumonia, and it's also used for nocardia as well. Doxycycline, again, similar to Bactrim, has spotty coverage of the gram-positives and anaerobes, not particularly good for gram-negatives, and has niche uses in chlamydia and rickettsial infection. The other non-beta-lactam of note is metronidazole, and metronidazole is the best anti-anaerobic agent, and so patients with intra-abdominal infection, oral pharyngeal infections, anywhere where there's an anaerobic component, metronidazole is usually used. Unfortunately, metronidazole doesn't have any activity against the aerobic organisms, so there's staph, strep, enterococcus, and coliform, pseudomonas, there's no activity, and so these organisms are usually present in these mixed infections and require coverage with additional antibiotics. So this is a full view of the spreadsheet that we have created, which lists the commonly available antibiotics that you'll use in your clinical practice versus the common bacteria that are found in most commonly found in human infections. And so this would be very useful for you to learn by rote, I think, for firstly passing exams, of course, but primarily for use on your ongoing careers as medical students and into internship and beyond. This is a very useful schema and should put you in a good stead. Of course, we haven't mentioned every single antibiotic that there is, and there's no doubt going to be other antibiotics released over the years, particularly with the advent of multi-resistant organisms. So on the subject of multi-resistant organisms, these are becoming much more of a problem in our hospitals and also the community, and will be a significant issue for you into your practice into the 21st century. So just considering Staphylococcus aureus, if it becomes acquires the MECA gene, it becomes resistant to all beta-lactams, and so you can see that this is really a problem. Now, of course, there is a new beta-lactam called ceftaroline, which has activity, but you can see as I fill this chart in that we've got ourselves a significant problem. Now, with respect to these non-beta-lactams, the drug vancomycin is used. Ciprofloxacin is usually resistant, and some of the community strains, but not multi-resistant strains, are susceptible to clindamycin and cotrimoxazole and doxycycline. So there is some activity there. The last group of antibiotics to be developed include linezolid. Now, linezolid has a particular place for treating resistant gram-positive organisms. So its spectrum activity against gram-positives is similar to vancomycin, except it also covers the vancomycin-resistant enterococcus. So VRE selected out by dual pressure, by lots of antibiotics being used, selecting out enterococcus species in the gut, and then you get issues with vancomycin exposure causing them to be VREs. And you can see we really don't have a lot of antibiotics for VREs. In fact, we have linezolid and plus some unusual antibiotics that are rarely used. So having a lot of problem with VRE is a substantial problem. This drug linezolid doesn't have any gram-negative action or anaerobic action. Now, the final class of MRO that we need to mention are the carbapenem-producing Enterobacteriaceae, and these are quite an incredibly resistant set of organisms. It's easy to fill this in, resistant to pretty much everything. And so if we get these causing outbreaks in our ICU, we've got a substantial problem because we really don't have much in the way of drugs to treat it. Sometimes they will be susceptible to one of the non-beta-lactams, and so to treat them, usually you use unusual drugs such as colistin or fosfomycin, and there are strains of the CPE which are not susceptible to available antimicrobials, and unfortunately we're going to see more of these in the future. So you can see in conclusion really that as we see more of these multi-drug resistant kind of organisms, that we're wiping out quite a bit of the green in this chart and replacing it with a lot of red, which signifies that really we do have quite a serious problem with the antibiotic resistance. This concludes the antibiotic lectures. Thank you for your time, and good luck in your exams and also your careers into the future. Bye-bye.